Okay, so it gives me great pleasure to introduce our first state-of-the-art talk. So our next speaker is Dr. Andrea Shin, who is a professor of medicine at the Indiana University, assistant professor of medicine at the Indiana University School of Medicine. And she also focuses on disorders of the gut-brain interactions. And, she has really established herself as a leading functional GI expert. And we asked her to present some abstracts tomorrow, but today she's also going to be giving the state-of-the-art talk and talking about biomarker-based approaches to the diagnosis and management of irritable bowel syndrome. So please welcome Andrea Shin.
I want to thank the conference organizers, including Drs. July and Australian Syndrome, for inviting me to join everyone today. For the next 35 minutes, I'll be talking about the topic of biomarkers in irritable bowel syndrome. And I have no relevant disclosures for this talk. So the objectives for the next 35 minutes or so will be, I'll start by providing a very brief clinical overview of irritable bowel syndrome, or IBS, and describe where we are in terms of our current diagnostic and therapeutic strategies and what their limitations are. And then I just want to focus the bulk of the talk on discussing peripheral biomarkers in IBS, and how we might use biomarker-based approaches for diagnosis and management. And then I will review where I think we may be with the clinical utility of available and investigational biomarkers, and then summarize what we know with what we have now and what we might anticipate in the future. So IBS is a very well-known common disorder of gut-brain interaction. It's also known as a lower functional bowel disorder, and it's generally defined according to symptoms. And the major hallmarks of IBS are recurrent abdominal pain in association with altered bowel function. The Rome criteria and other symptom-based diagnostic criteria are frequently used to define IBS. And the most recently updated version of Rome, or Rome 4, defines IBS according to the presence of recurrent abdominal pain occurring at least once per week. That is also associated with at least 2 or more of the following: pain that's associated with defecation or associated with a change in stool frequency or stool form. And then we have our different IBS subtypes, which are then defined based on the predominant bowel pattern. One important note that I want to make is that bloating and distension are common features of IBS, although they're not actually included in the formal diagnostic criteria. So in recent years, and through the efforts of active investigation, it's been recognized that IBS represents a very complex number of pathophysiologies that can include disturbances in distinct central and peripheral mechanisms. And it's precisely our advances in conceptual understanding of IBS pathophysiology that have guided the development of IBS-specific therapies. For example, the use of intestinal or secretagogues to stimulate intestinal fluid secretion, the use of 5-HT4 agonist or 5-HT3 antagonists that leverage our understanding of the role that serotonin plays in the gut. Antidepressants, neuromodulators, psychological therapies, these target the central nervous system and visceral afferent signaling pathways. And we even have, for example, non-absorbable antibiotics that are approved for the treatment of IBS that are based on the premise that we may be able to target the intestinal microbiota or maybe changes in barrier function. And then also, very commonly applied dietary approaches. Again, this is based on our understanding of pathophysiology and the premise that bacterial fermentation of food substances in the gut can lead to IBS symptoms. Despite the knowledge that we've accumulated over the recent decades in IBS pathophysiology, our diagnosis and treatment approach continues to rely mostly on patient symptoms. And we recognize that IBS is a very clinically and phenotypically heterogeneous group. There's no single diagnostic algorithm that we can apply to all of our patients. And ultimately, we are trying to exclude other disorders that may have a similar presentation and establish our diagnosis based on 3 key features, which are typically history, physical exam, and a limited number of testing where appropriate. It's important to ask about symptoms, psychosocial factors, presence of alarm symptoms, relevant family history. And of course, a physical exam is also often important, that initial encounter too, because this provides a patient some degree of reassurance, and then also is an opportunity for us to screen out clearly abnormal findings. And then beyond that, the use of specific laboratory tests or endoscopic evaluation is really tailored depending on the patient's history and their presentation, including their symptoms, their environmental environmental factors, their personal and family risk factors. Oftentimes, however, in the absence of clear red flags or clear symptoms that would indicate the need to rule out other disorders, we can be fairly confident in a positive diagnosis of IBS based on symptoms and initiate treatment based on that. So not too long ago, the AGA published their guideline on laboratory evaluation of functional diarrhea and IBS-D in adults. And this was a guideline using grade methodology, using the strength of the available data. And as you can see, the reason I included this is that really there are a very limited number of tests that are recommended in the absence of specific clinical features. So again, we're taking history and then moving on from there. Strong recommendations are made for testing for stool giardia, for example, and ruling out celiac disease, conditional recommendations for testing for bile acid malabsorption, and then obtaining a fecal calprotectin to screen for inflammatory bowel disease. So once our diagnosis is established, the first step in therapy is first establishing a strong relationship with our patient. And this is our opportunity to provide education and reassurance and determine their goals and concerns. And then we tailor our treatment plan based on their symptom severity and on patient priorities. And that first step usually involves a conversation around lifestyle modifications, and then also understanding what their motivations are, what specific factors might affect the type of care that they might seek, and their major predominant symptoms so that we can select the best treatment approach for them. There are a number of approaches that we can use: dietary approaches, pharmacologic approaches, psychological treatments, sometimes even complementary and alternative treatments. And these can be applied in either a stepwise manner or even in a parallel fashion, again, depending on the individual patient. So as I had mentioned before, there's really no universal algorithm applied to all patients, but a practical algorithm can sometimes involve, again, initiating first-line therapy that's targeted to their major symptoms. And so this is where you might want to try and better phenotype them in terms of what are the major drivers in their presentation. And then at that point, if patients don't respond to initial first-line therapy, additional evaluation is sometimes recommended. And this is where we have the opportunity to maybe assess for specific pathophysiologic features that could then further help us refine our therapy. And this is probably where biomarkers are being more commonly used or applied in IBS in the current setting. I showed the AGA guidelines earlier, and remember, we have a very limited set of diagnostic laboratory tests that can be applied in a broad IBS population. But mostly the purpose of these biomarkers is to exclude other disorders and thereby support a diagnosis of IBS rather than obtain a positive diagnosis of IBS or pinpoint a specific mechanism. So for that reason, we do have a clear need to develop usable tools that can allow us to more effectively identify and treat patients with IBS. Developing IBS biomarkers will be important because they can help support a positive diagnosis of IBS, help us identify specific pathophysiologic features that could be targeted for treatment in an individual patient. Biomarkers can also be used to monitor treatment adherence and treatment response. And then ultimately, the goal is to utilize biomarkers so that we can develop cost-effective approaches for evaluation and management as we move towards precision-based medicine. So in that quest to develop usable clinical tools, a number of biomarkers have been studied in IBS over the years. So today I'm just going to take some time to highlight some of the more notable biomarkers that have been studied in IBS. I'll be focusing specifically on peripheral biomarkers, such as tests for bile acid malabsorption, colonic transit, breath testing for bacterial overgrowth, rectal sensation testing, intestinal permeability, anti-CdtB, anti-vinculin, and then a few investigational biomarkers like serotonin and mucosal mast cells. Biomarkers that are related to the central nervous system and the GI microbiota, I won't specifically cover those today because, again, those are very vast topics as well, and I think we'll focus mostly on the peripheral mechanisms. So the first biomarker that I wanted to talk about was anti-CdT or anti-vinculin. I'm sure many are familiar with this test. So cytolethal distending toxin, it's a neurotoxin produced by bacteria that cause acute gastroenteritis, most notoriously associated with Campylobacter jejuni, but can also be produced by Salmonella, E. coli, Shigella. And it cross-reacts with the protein vinculin within the gut mucosa. And so that's why there are these dual antibodies that can be assessed, CdtB and vinculin. So several years ago, researchers assessed circulating levels of anti-CdtB and anti-vinculin in patients with IBS-D from a large multi-center therapeutic clinical trial, the Target 3 trial. And they also recruited healthy controls, patients with inflammatory bowel disease and celiac disease. And it was a pretty large cohort of over 2,600 patients, the large majority of whom had IBS-D. And they performed ELISA testing on plasma samples and measured optical densities to look at circulating levels of anti-CdtB and anti-vinculin, and then constructed their receiver operating curves and determined specificity, sensitivity, and likelihood ratios. So in total, as I mentioned, they recruited over 2,600 participants, and they observed that overall, the levels of anti-CdtB were highest in IBS compared to the other non-IBS groups. They also observed that levels of anti-vinculin were also highest in the IBS group compared to the non-IBS groups. For anti-CdtB, another observation that was made was that it was higher in celiac disease compared to the other non-IBS groups, although again, as I mentioned before, it was highest in IBS-D. So based on these data, they constructed their receiver operating curves, and they assessed the discriminatory ability of IBS-D, anti-CdtB and anti-vinculin to differentiate IBS-D from inflammatory bowel disease. And based on this, they identified optimal thresholds for both biomarkers. For CdtB, they identified that as at least 2.8 or higher, with a sensitivity of about 44% and a specificity of 92%. And for anti-vinculin, the threshold was 1.68 or higher, with a sensitivity of about 33% and a specificity of 84%. So based on these performance characteristics, it was concluded that a positive test could be useful in confirming a positive diagnosis of IBS-D compared to inflammatory bowel disease, although the sensitivity was rather low. So a couple of follow-up studies were then performed to assess the diagnostic accuracy of these markers in other study populations. A few years ago, Max Schmolson and colleagues in Mexico reported their own clinical experience with these biomarkers, and they observed that positive biomarkers were more frequently noted in those with IBS-D and IBS-M, but not in patients with other functional GI disorders or other causes of chronic diarrhea. They did also notice that those with post-infection IBS seemed to have higher rates of this biomarker, although there was no statistically significant difference compared to the non-post-infection IBS. But then just a couple of years ago, Nick Talley and colleagues then examined these biomarkers in their own cohorts, including a population-based cohort and an outpatient clinic-based cohort. And they did observe higher levels of anti-CdtB in functional dyspepsia and in IBS functional dyspepsia overlap compared to healthy controls. But when they tried to use the previously published threshold cutoff to discriminate the patient groups, they weren't able to identify any significant separation of the groups using the previously published cutoffs. So unfortunately, they weren't able to fully validate anti-CdtB and anti-vinculin in their own separate cohorts, which were population-based and outpatient clinic-based. So the conclusion here so far is that, again, based on the original data, it seems that there may be some reasonably high positive predictive value, but the sensitivity of the test is fairly low. So far, the methods and performance characteristics of these tests are not fully validated in uninvestigated patients, but I think this is probably something that warrants us keeping an eye on. It could potentially be more useful in the future once identification of, for example, a specific post-infection IBS cohort could actually lead to targeted therapies or may change our management in the future. The next test that I want to talk about is breath testing for bacterial overgrowth. I've included this one in the talk today, even though many might argue that it's not really an IBS biomarker, but a test to look for an alternative diagnosis. But I mentioned it because small intestinal bacterial overgrowth is such a poorly defined syndrome, and it has a lot of features that does overlap with IBS. And some may actually argue that it may be a mechanistic subtype within a very heterogeneous IBS group. So breath testing, just as a reminder, it's a non-invasive test, and it is used to detect SIBO based on the premise that luminal hydrogen and methane gas will be produced by bacterial fermentation after ingestion of a carbohydrate substrate. That this gas then rapidly diffuses across the mucosa and then is excreted in the exhaled breath. There are a number of challenges with the breath test, however. Of course, it can be affected by the microbial composition, by the types of bugs that live in the gut. Transit can lead to false positives, especially if you have faster transit, can be affected by carbohydrate malabsorption, oral contamination, and other external factors like diet, smoking, and exercise. So some of the debate around the utility of the breath test includes also observations that prior studies haven't clearly shown that, for example, the lactulose hydrogen breath test can clearly discriminate between patients and healthy controls. And this is also an area where we continue to lack a true gold standard. And so we can't fully validate the performance characteristics of the breath test. And so with that in mind, researchers have still tried to examine the link between SIBO and disorders such as IBS. Although a lot of prior work has produced some conflicting results. One recent systematic review and meta-analysis that was published in the Red Journal in 2020 did report that SIBO prevalence rates do appear to be higher in IBS compared to controls, even when they limited their meta-analysis to high quality studies only, and I've included that forest plot here. In particular, the odds ratio for SIBO in IBS compared to controls was 6 when using a glucose hydrogen breath test and was 2.3 when using a sucrose breath test. The odds ratio was lower with a lactulose hydrogen breath test at 1.6, and the confidence interval did cross 1. In this meta-analysis, it was also noted that the lactulose hydrogen breath test seemed to contribute to the most degree of heterogeneity across studies. So although in this review, again, there is evidence to suggest that perhaps a SIBO might be correlated or linked to IBS, it is still limited by the fact that there was a lot of clinical heterogeneity across the studies that were included in the meta-analysis. And again, the overall quality of the evidence is continued to be rated as low. Now, despite these limitations, others have then gone on to look at the question, well, perhaps breath testing could still be useful, for example, in predicting response to treatment. Rifaximin, as most are familiar with, is approved for the treatment of IBS-D. And although the mechanism of rifaximin in terms of how it is beneficial in IBS is not known, there was a study that went on to look at a small subset of patients that had been included in the original Target 3 trial and examined the role of baseline lactulose hydrogen breath test and how that might predict clinical response. In this study, it was shown that baseline lactulose hydrogen breath testing was correlated with clinical response. So positive breath test at baseline was associated with a higher rate of response. Unfortunately, though, the post-treatment breath testing results didn't correlate with response. And so it remained unclear if the symptom response to rifaximin was truly related to SIBO treatment or eradication. The other fact to consider is that, and I probably should go back to the prior slide, in the systematic review and meta-analysis, one of the other subgroup analyses that they performed was looking at IBS subgroups, and they did know that SIBO rates tended to be higher in IBS-D versus IBS-C, again, raising the question of intestinal transit and how that affects test positivity. So again, whether baseline lactulose hydrogen breath test is a predictor for a response to rifaximin because of a SIBO effect or because of a transit effect wasn't quite clear. There have been some recent consensus efforts to help harmonize this approach, and there have been some growing technical advancements in our knowledge of the small intestinal microbiota. So this may ultimately aid our ability to better define the clinical entity of SIBO and consider breath testing or its role in evaluating patients with IBS in the future. Another pathophysiological mechanism that has been studied in IBS and has really lended itself as a putative IBS biomarker is intestinal permeability. So a lot of people have probably heard the term the leaky gut. Leaky gut and barrier dysfunction have been linked to visceral hypersensitivity and pain in IBS. These are a couple of figures from a systematic review published by Hanning and colleagues. And in this review, the authors examined the literature to identify studies describing permeability in IBS. And overall, they did observe that the prevalence of barrier dysfunction ranged anywhere from 17 to 50%. And impaired permeability was more common in IBS than in controls, particularly in those with IBS with diarrhea or post-infection IBS. As you can see here, the observed effect was stronger in smaller studies, but the conclusion from this review was that barrier dysfunction does appear to be common and is also positively correlated with symptoms, including bowel dysfunction. Now, how do we assess barrier dysfunction? There are a number of methods that we can use, including in vitro methods, ex vivo methods, in vivo methods. This is a figure from that same review that essentially summarizes all the different types of in vitro and ex vivo methods that were used to show changes in barrier dysfunction. It just shows that there is a wide array of tests that are available, and there is heterogeneity in methods across studies. The one approach, for example, in vivo assessment of intestinal permeability that may have the most consistency to it includes the use of probe-based testing. And I'll move on to a slide here. And this is probably where we might be closer to developing potentially an accurate test that could, where we could assess intestinal permeability as a biomarker in IBS. Recently, a group of investigators set out to optimize the methods of in vivo permeability testing, which requires the ingestion of saccharide probes. And in this study, the study included 60 healthy volunteers, both men and women, and participants were randomized to 3 studies. So during 2 of the studies, they ingested about 16 grams of fiber on a standardized diet. They did that twice to look at the reproducibility of the test. And then in a separate study, they then ingested a higher amount of fiber of approximately 32.5 grams of fiber daily to examine the effect that fiber intake had on the testing. During these diets, they ingested several different mono and disaccharide probes, including carbon 13 mannitol, carbon, 12 mannitol, rhamnose, sucralose, and lactulose. And then they obtained urine collections at varying time points to measure small and large bowel permeability. They did observe that age, sex, and BMI didn't seem to have a significant effect on the testing. And overall, the test was fairly reproducible. Ultimately, they determined the optimal probe for small bowel permeability to be carbon 13 mannitol because it does have a very low rate of baseline contamination because it is not naturally occurring in the diet. And then the optimal probes for colonic permeability were lactulose excretion at 2 to 8 hours or sucralose excretion at 8 to 24 hours. So again, I think these data suggest that the results are very promising in terms of methods to assess in vivo permeability. This was a smaller study and further validation is still needed, especially with regards to standardizing diet approaches, but it probably is a test that will become available as a clinically useful diagnostic test in the future. And is also important because it can give us objective measurements of altered barrier function, which may have implications for clinical trials. Another biomarker, another test that I want to discuss, and one that is immediately available, are tests for bile acid malabsorption. So bile acid malabsorption is a common mechanistic subtype of IBS. It can occur in up to a quarter or a third of patients with IBS, and this has been well demonstrated in a number of systematic reviews over the years. And prior clinical studies have shown that fecal bile acids are correlated with clinical phenotype. Multiple studies published by Matt Camilleri's group at Mayo Clinic have shown that both total and individual fecal bile acids are associated with IBS phenotype. So in general, we see higher levels of fecal bile acids in IBS-D, as well as higher levels of secretory bile acids, including chenodeoxycholic acid and deoxycholic acid, while there tend to be higher levels of non-secretory bile acids, lithocholic acid in IBS-C. In terms of its utility as a quantitative biomarker, it's been shown that both total and primary fecal bile acids can also predict clinically significant bowel dysfunction. So for example, excreted fecal bile acids can predict fecal weight, stool frequency, and stool consistency. There are other methods that have been offered to assess for bile acid malabsorption as well, including serum C4 and random spot testing of primary bile acids in stools. And in this recent study that was published by Priya Vijayvargiya, it was shown that combined together, serum C4 and a random stool test for percent primary bile acids, again, could identify bile acid diarrhea as well as changes in bowel function. It is important to note, you may see serum C4 checked quite frequently, but it does require specialized testing. So just getting a random C4 probably isn't accurate. It does exhibit diurnal variation as well. So it is a test that needs to be checked as a single fasting AM sample. Additionally, although these data are promising in terms of getting a random stool sample, further studies are still required to try and determine the optimal timing of that single stool collection, as well as whether any dietary intake needs to be controlled. In terms of its diagnostic accuracy, like I said before, fecal bile acids do predict quantifiable changes in bowel function. It's also been combined with colonic transit, and together colonic transit and fecal bile acids perform very well as quantifiable biomarkers. They do distinguish between healthy volunteers and patients with IBS and can also discriminate between IBS subtypes as well. And so for this reason, measurement of excreted fecal bile acids has been validated as a diagnostic tool in IBS. It can theoretically guide treatment selection, for example, the use of a bile acid binder or sequestrant, perhaps encourage adherence to therapy and offer a basis for treatment. Of course, the major argument is that an empiric trial of a bile acid binder may be more convenient. And in many cases, that may be the approach that is taken with the patient. But for patients who are challenged by trying to adhere to therapy or finding the optimal dosing regimen, having objective data to support the treatment rationale can be helpful. Colonic transit, although it can be combined with fecal bile acids, has also been proposed as a quantitative biomarker on its own and could be relevant for the management of patients with IBS. Although altered transit is not a universal feature in IBS, altered motility can be present in certain IBS subsets, and that's been shown previously. This is a figure from a paper by Tornblom and colleagues from about 10 years ago. It was noted in the study as well that colonic transit also correlates with bowel functions like stool form and frequency, but not so much with pain, bloating, and flatulence, which raised the question of whether or not overall colonic transit is clinically important or significant for patients with IBS. Now, 10 years later, a separate study from the same group examined the relationship between neurophysiological measures and GI symptoms in IBS. And they did note that colonic transit or motility, which is shown here, was among the few sensory motor mechanisms that did differ significantly between the clinical groups. And then in this study, they also looked at the associations between neurophysiologic parameters and GI symptoms using the GI symptom rating scale. And colonic transit, again, was among the few neurophysiologic parameters that exhibited the strongest relationship with symptoms, highlighting the contribution that transit could have on symptom generation among patients. Others have taken this a little bit further to assess if and how transit can quantify a response to treatment. This is a table from a very small study of 13 patients who were studied on linaclotide to examine the effect of linaclotide on GI physiology and the relationship between changes in physiology and changes in symptoms. And in this study, they did observe that linaclotide was associated with an acceleration of colonic transit, as shown here, and also associated with a change in pH across the ileocecal junction. Unfortunately, they did not see that a change in transit actually correlated with change in symptom scores. However, the change in pH did. And although they weren't able to observe a direct relationship between the overall change in transit and change in symptoms, it was hypothesized that that change in pH could actually represent decreased cecal fermentation, which would have been a consequence of faster colonic transit and perhaps right-sided colonic transit or segmental colonic transit. So for this reason, there is still data suggesting that colonic transits do provide useful clinical insight and might be a quantifiable target for the development and use of specific IBS therapies, and perhaps more informative if we can complement overall colonic transit assessments with segmental colonic transit. Rectal sensation, this is another tool that I wanted to bring up. It's another quantifiable aspect of neurophysiology. It's frequently linked to IBS and visceral hypersensitivity. This is a figure from an older study of about 100 patients. And in this study, it was shown that altered rectal perception or rectal hypersensitivity was common in IBS and was also an important factor in GI symptom severity, as shown here, and also associated with diarrhea, bloating, and pain. They did notice that rectal hypersensitivity did have high proportions of both constipation and diarrhea predominant phenotypes, suggesting that it is a common feature, even among a heterogeneous patient group. Now, recently, investigators have tried to study the mechanisms that might contribute to altered perception by studying rectal sensitivity, intestinal permeability, and transcriptomics. This is a figure from a pilot study that assessed 26 patients with IBS. And in this pilot study, it was observed that rectal sensation actually did correlate with changes in small intestinal expression of TRPV channels, specifically TRPV1 and 3, which are nociceptors that can mediate pain. And based on these data, it was suggested that perhaps rectal hypersensitivity could be mediated by intestinal chemosensitivity. Rectal hypersensitivity is often considered a pathognomonic feature in IBS, but its utility as a clinical biomarker has often been limited. Satish Rao had published their data recently looking at patients with IBS-C and rectal hypersensitivity to demonstrate that those with rectal hypersensitivity were more likely to respond in terms of their hypersensitivity when they were treated with sensory adaptation treatment over a pharmacologic agent like escitalopram. But this was only for the hypersensitivity outcome and not specifically for abdominal pain. So for this reason, although it is a common feature and it is a feature that we can measure and assess today using our currently available tools, it is a biomarker that has been fairly limited in its overall utility. Perhaps it could be more useful in the future once the mechanisms that elicit hypersensitivity could be more precisely identified and also targeted in terms of therapy. So the last two biomarkers that I just want to finish up discussing are potential investigational biomarkers. The first of these is serotonin. Most are familiar that serotonin is an important neurotransmitter in the gut that modulates both GI physiology and behavior. The intestinal enterochromaffin cells produce about 95% of the body's serotonin, and serotonin can modulate both GI physiology and behavior. It is synthesized from tryptophan by tryptophan hydroxylase, and serotonin levels are also controlled by the serotonin reuptake transporter, which inactivates serotonin, which is subsequently broken down into its metabolites, including 5-HIAA. Despite the fact that serotonin is widely recognized for its role in modulating gut physiology, quantifying it is exquisitely difficult. This is due to variations that can occur with sample processing, the effect of fasting versus postprandial states, the expression and the activity of SERT, the transport of serotonin across liver, lung, platelets, and the effect of other psychological comorbidities or even medications. And then also when we measure plasma or when we measure peripheral circulating serotonin, we're not really measuring serotonin at its site of action. Some have attempted to try and quantify serotonin by taking into account not only serotonin levels, but its metabolite 5-HIAA. Thichson and colleagues recently reported that 5-HIAA levels were consistently lower in IBS subtypes relative to controls, even after they controlled for age, sex, medications, suggesting that perhaps there may be ways that we can measure serotonin more accurately in the future. They did not observe any differences across IBS subtypes, however, and reasons for that were not fully explained. Some have looked at genetic variations in the polymorphic region of the gene that encodes SERT. However, one systematic review and meta-analysis that looked at the relationship between these genetic polymorphisms in IBS revealed that overall there was no significant association, with the exception of gene polymorphism association with IBS-C in East Asian populations, but not necessarily in Caucasians. So this has then led to suggest that perhaps evaluation of genetic variations might be more useful for predicting, for example, response to drug therapy. But again, its role as a broad biomarker in IBS is probably going to be more limited. And then finally, I want to just touch on mast cells. This is a topic that continues to attract attention. Increased mast cells have been described in IBS in several systematic reviews and meta-analyses, both in the colon and in the small intestine. However, absolute mast cell counts, the numbers often overlap with what's described in healthy volunteers. And so it's not quite certain if mast cell quantification has any clear diagnostic value as a biomarker. Some clinical studies have looked at the use of mast cell stabilizers like ketotifen for increasing the thresholds for abdominal discomfort. This is a figure from a study that evaluated the effect of ketotifen in patients who were normosensitive and hypersensitive, and it was shown that the agent could increase the threshold for pain and also decreased other IBS symptoms and improved quality of life. However, they didn't notice that there was actually any measurable change in mast cell mediators such as histamine and tryptase. The same group then went on to potentially hypothesize that the beneficial effects of ketotifen might be mediated through its histamine receptor block antagonizing effects. So in a separate trial, Wolters and colleagues examined the role of Avastin, which is a histamine receptor antagonist, and similarly showed that this could reduce symptoms as well. And this is a figure from that study that I've included here. Other researchers have tried to examine the mechanisms by which mast cell mediators might trigger visceral hypersensitivity. This is a figure that was from a study recently published in Gastro, looking at supernatant from colonic mucosa in patients with IBS-D. And in this study, it was revealed that the IBS-D patients exhibited higher levels of mast cell mediators, including histamine, tryptase, and PGE2. They also saw higher levels of COX-2, which is the rate-limiting enzyme that regulates synthesis of PGE2. And through their experiments, their studies actually suggested that it was abnormal synthesis of PGE2 that seemed to be causing visceral hypersensitivity. And so in other words, although histamine and tryptase are important mast cell mediators, they didn't appear to be the final mediator. And instead, their actions on visceral hypersensitivity seem to be dependent on PGE2 synthesis. And this might, again, be in agreement with the prior study by Wolters and colleagues who demonstrated the effects of Avastin. But overall, these are really useful insights that will probably guide the development of future randomized trials or studies that target mast cell dysfunction as an IBS biomarker in the future. So to wrap it up, this is a table just summarizing the biomarkers that have been discussed today. Anti-CdtB and anti-vinculin have been proposed as diagnostic biomarkers with reasonably high predictive value, but they are limited by low sensitivity and further validation is required. Breath testing for SIBO could theoretically be considered as a mechanistic biomarker in IBS. There have been recent consensus documents that have allowed us to develop a more consistent framework for methods and interpretation, but there still remains no gold standard to validate the test, but it could be a useful test in select individuals considering the limitations, and it could help, for example, determine the need for antibiotic therapy, although it may not guide a specific antibiotic selection. Intestinal permeability can be assessed in vivo. This demonstrates good performance characteristics in healthy volunteers. It is feasible in IBS. It's a non-invasive test, and again, probably something that we may be seeing more of in the future, but additional validation is required. Fecal bile acid measurements, these are currently available. They are well validated. Major limitations are that it can be cumbersome for patients, and some patients may simply prefer to proceed to a therapeutic bile acid binder. Serum C4, this is a mechanistic biomarker. Again, recall that it may exhibit diurnal variation. It has greater specificity when you do combine it with stool testing. Colonic transit testing, this is very well validated, can assess physiologic parameters, again, is more indicative of a mechanism in IBS, can correlate with symptoms and treatment response, but in certain areas, there may be limited availability. Rectal sensation, rectal hypersensitivity represents a hallmark feature in IBS, could be a diagnostic biomarker, may guide treatment selections in the future, but at this point it is invasive, there is limited availability, and it may not correlate with individual symptoms, and so its wide utility is probably more limited. Serotonin and mucosal mast cells, these are more investigational biomarkers, but again, I just summarized that here on the table here, but they may represent promising avenues for novel treatments in the future. And then again, that brings us back to our proposed framework. Currently, we initiate treatment based on symptoms, and then we may integrate a biomarker-based approach to help us refine our treatment approach. And again, future targets are probably available in the future, in the near future. Again, they may be selected based on predominant symptoms. Currently, there's no universal biomarker in IBS due to its heterogeneity. Biomarkers should identify treatable mechanisms that enable individuals to obtain an informed diagnosis. There are some that are currently available for immediate use, but there are promising biomarkers that are under active study, may allow us to select biologically informed therapies, assess treatment responses, and develop novel treatments in the future.
Thank you so much. And I encourage you to come up to the microphones if you have any questions. And I'm not sure if you can see the chat at all, but if there are any questions there, we'll try to get those as well. But I'm going to start it off with a question. First of all, that was outstanding, Andrea, and thank you. So it reminded me a little bit of Dr. Dulais talking about precision immunology, because despite all of that, all the work he's doing, people still give steroids, right, for inflammatory bowel disease. And despite all of the different mechanisms that you talked about and potential biomarkers, people still just give fiber sometimes but you're seeing industrial strength IBS patients. If at some point, clinicians in practice are going to be utilizing biomarkers and additional diagnostic studies, it may take us longer to deliver care for patients up front who have been potentially suffering for a while. So right now, what is your current approach? Because it seems like the clinical history is still going to be really relevant, right? So if a patient has like post-infection IBS, we'll have some sort of clinical history to guide us in that direction. How are you approaching a patient that you're seeing for the first time, that you suspect IBS, and you're thinking about what's your kind of first line approach?
So I do use more of a clinical symptom-based approach as first line. And then in terms of whether or not we want to apply objective quantifiable testing, I'll usually work that in later on in my algorithm if they're not responding to empiric therapy that has been selected based on what I think might work for them. But again, some of the role of biomarkers, I think, will also have a major impact when it comes to designing future randomized controlled trials to look for other markers of objective response rather that can complement patient-reported outcomes.
Thank you. And in terms of the kind of utility of some of these biomarkers, such as the rectal sensitivity, et cetera, again, an invasive approach, with respect to what is currently available in clinical practice, what do you think is the most kind of frontline biomarker that is going to be readily accessible to people in the community?
So I think out of the ones that I talked about today, the ones that are most accessible for community-based clinicians are probably transit testing and breath testing. That's why I did talk about breath testing today, just because I think it's so widely available and it's widely used, but it does have some major limitations that I think need to be recognized when we use them. Transit testing, even though that's widely available, it's more usually in the setting of abnormal versus normal transit. And if some of the data that I discussed today, it may be more informative if we can get actually quantifiable transit, or, for example, information about segmental transit. So in that setting, even though it is widely available, the information that it gives in a community setting is probably less quantitative.
Great. Thank you so much, Andrea. Thank you. Let's give her another round of applause.